Hello everyone, welcome to this recall session of the FMGE July 2025 paper. Now, as far as the FMGE July 2025 is concerned, some few pointers before I actually discuss the question. Most of the questions, most of the questions were previous year questions and from previous year topics. There's not even a single question which was not a PYQ or a PYT. Barring some 10 or 20 questions which obviously are going to be new, but most of the questions, if I talk about pediatrics per se, even the general paper also, most of the questions were, I would say, easy to moderate. Most of the questions were easy to moderate. Yes, there were definitely some hard questions, but definitely easy to moderate. The paper was a little bit, as you must have observed, it has started to become NEET PG-ish like. It has started to become NEET PG-ish like. But the good thing was, although the questions they are trying to make more NEET PG-ish like instead of one-liners, most of the questions were from previous year questions and previous year topics. It was not something which you are not done in your notes. Most of the questions can be easily be solved, especially if for those who have attended the DBMCI sessions in the last 6 months, the offline on the online classes, especially from me, most of the questions were from the notes. There was not even a single question which was not from the notes. All right. So if your preparation is focused and it is focused on most of the important topics, what are the important topics? The previous year question and the previous year topics. There's nothing that can stop you from passing the exam. Forget passing. Nothing can stop you from getting a 200 plus in the exam. On that note, let's begin the discussion. So first question, a 6-month-old child. So 6 months means a 6-month-old infant child. He has presented to you with sudden brief spasms. So infant with spasm, this is what? This is infantile spasms. Whenever an infant presents to you with spasms, it becomes what? It becomes infantile spasm. And if there are infantile spasms, it is what? It is nothing but West syndrome. It is nothing but what? West syndromes. All right. EG showing a hips arrhythmia pattern. So West syndrome has hips arrhythmia. That's what we know, right? This is hips arrhythmia, and they've given you a photo of hips arrhythmia. All right. Question is, what is the first line treatment? So we all know that as far as West syndrome is concerned, what is the drug of choice? The drug of choice for West syndrome is ACTH. It is ACTH, and this is a previous year question as far as FMGE is concerned. If I'm not wrong, 3 or 4 years back, this was asked in verbatim the same manner, right? So ACTH is the drug of choice. All right, we all know as far as West syndrome is concerned. So they're giving you a clinical scenario of West syndrome with infant presenting with spasm, infantile spasms, EG showing you hips arrhythmia, then asking you what is the drug of choice. All right, the drug of choice is going to be ACTH, and hence option A, ACTH is going to be the correct answer. The correct answer is going to be option A. Option A will be the correct answer. All right. Now, let's go to the next question. All right. A child presents with recurrent sinusitis and recurrent lung infection. So, recurrent LRTI and sinusitis. You know where this is going. By this itself, you should be able to at least think of a differential diagnosis. It's going towards cystic fibrosis. LRTI plus sinusitis, always think of cystic fibrosis. All right. The genetic testing has already revealed a mutation in the CFTR gene. So, I've given you the diagnosis. CFTR mutation means what? It is CF. CF is what? It is nothing but cystic fibrosis. Then they're asking which test is considered the gold standard for making the diagnosis. See, the gold standard in cystic fibrosis, we all know. In cystic fibrosis, what happens? In cystic fibrosis, there is increased sweat chloride, and it becomes more than 60 milliequivalent per liter. All right, it becomes more than 60 milliequivalent per liter, and when you detect this on 2 or more separate equation, that is considered the gold standard. That is the first line investigation as far as cystic fibrosis is concerned. The answer here is going to be a sweat chloride test. That is, again, option A is the correct answer. Again, this also has been asked. Increased sweat chloride is the characteristic and the most defining feature as far as cystic fibrosis is concerned. So if I talk about the diagnostic criteria, of cystic fibrosis, the first diagnostic criteria is increased sweat chloride. It is increased sweat chloride more than 60 milliequivalent per liter on 2 or more occasions. If that is not there, you can do genetic testing. You can do a genetic analysis. If genetic analysis is also not coming out to be positive, you can do you can test for abnormal nasal potential difference. Any one out of the following, any one out of these 3, you will consider it to be a cystic fibrosis case. All right, so this was a simple question. You have a child who has cystic fibrosis. What is the confirmatory test? The confirmatory test is increased sweat chloride. So sweat chloride test is the answer. Now we move on to the next question. All right. So a 4-month-old has been brought to the emergency department with a respiratory rate of 66. Okay. With chest indrawing. So we know this is going towards pneumonia. Child was not able to feel and lethargic. So not able to feel lethargic. These are what? These are the danger signs. These are considered the danger signs. Anytime you have danger signs, it automatically becomes what? It automatically becomes severe pneumonia. It automatically will become severe pneumonia. If I talk about the IMNCI management, let's just talk about a little bit about the IMNCI management. Let's talk a little bit about the IMNCI management of pneumonia. If I talk about the IMNCI management of pneumonia, so this is a page from my own, this is a page from the notes that we have made. We have discussed this in the class. All right. So IMNCI management. So as far as IMNCI management is concerned, let's see. If a child presents to you with only cough and cold, maybe wheezing, that is no pneumonia. If a child presents to you with fast breathing and we have respiratory rate cutoffs as far as fast breathing is concerned, or with chest indrawing, it becomes pneumonia. But if a child presents with poor feeding, lethargy, high grade fever, seizures, or a fall in SpO2, then it becomes severe pneumonia. All right. So this is going to be severe pneumonia or very severe disease. So this is from the notes that we are discussing in the class itself. All right. We are discussing this in the class itself. The answer is going to be severe pneumonia. Answer is going to be option B. That is severe pneumonia. Severe pneumonia is the one that's going to be the answer. All right. Because of what? Because of this not able to feed and lethargy. If they had not given you this not able to feed and lethargy, then the answer would have been pneumonia. But because they have given you these danger signs, it becomes what? It becomes severe pneumonia. Moving on to the next question. Which of the following is considered harmful to a newborn baby in the immediate postnatal period? Which of the following is considered harmful in the immediate postnatal period? The answer here is going to be option B. The answer is going to be option B is the correct answer. See, if you bathe the baby immediately after birth, this can increase the risk of neonatal hypothermia. Alright, we have discussed this when we are discussing neonatal hypothermia, that a neonate loses heat by conduction, evaporation, convection and radiation. We had discussed this when we were discussing that there are 4 mechanisms. One second. There are 4 mechanisms by which a baby loses heat. Conduction. How do we prevent conduction? By keeping the baby on a warm surface. It loses heat by evaporation, by keeping the baby dry. Alright, it loses heat by convection, by whenever there is an airflow, and it loses heat by radiation. If you bathe the baby in the first 24 hours, alright, or immediately post-birth, that water is going to evaporate and contribute to heat loss, leading to neonatal hypothermia. That is the reason giving bath immediately after birth is considered harmful. Rest everything is not considered harmful. If you initiate, yes, you have to initiate breastfeeding within the first hour. You have to initiate breastfeeding as soon as possible. If you place the baby on the mother's chest, that is going to decrease the risk of neonatal hypothermia. Because the heat transfer will occur from between the mother and the baby. Right? So the answer is don't bathe the baby on the first day. We had discussed this in the class, right? The answer is immediately giving the birth after birth, it's going to be harmful to the baby. Next, we move on to the next question. A 2-week-old presents with high conjugated bilirubin. Okay, so high conjugated bilirubin. If there is high conjugated bilirubin in a 2-week-old, this is what? This is neonatal cholestasis. As far as neonatal cholestasis is concerned, what is the most common cause of neonatal cholestasis? The answer is biliary atresia. If I look at other options also, what is the most likely diagnosis? See, answer is going to be biliary atresia, but let's look at other options also. Physiological jaundice results in an increase in unconjugated bilirubin. Crigler-Najjar syndrome also results in increase in unconjugated. In Crigler-Najjar, there is absence of conjugating enzyme. There is no conjugating enzyme. Because there is no conjugating enzyme, that's why the unconjugated bilirubin increases. Again, so Crigler-Najjar, even in physiological jaundice, there is increase in unconjugated. Even in Gilbert syndrome, there is increase in unconjugated bilirubin. So if they are giving you that there is high conjugated bilirubin, and the most common cause of neonatal cholestasis anyway is biliary atresia, the answer is going to be option A. Answer is going to be option A. That is biliary atresia. Biliary atresia is the answer. Moving on to the next question. A 5-year-old child has come with exertional dyspnea and history of cyanotic spells. Okay, so he has come with cyanotic spells. So first thing is, this is a cyanotic congenital heart disease. This is going to be a cyanotic congenital heart disease. Alright, and then they have given you an X-ray. If you look at the X-ray, can you make out the figure of 8 appearance? Can you make out the figure of 8 appearance? Alright, or what I also sometimes is called the snowman appearance, which is also sometimes called the snowman appearance. The answer here is going to be, if there is going to be a snowman appearance, the answer is going to be what? Total anomalous pulmonary venous connection. The answer is going to be TAPVC. TAPVC. This is also this is a verbatim PYQ. This has been asked both in NEET, this has been asked as far as FMGE also is concerned. See, in tetralogy of Fallot, you would have seen a boot-shaped heart. You would have seen a boot-shaped heart. As far as TJ is concerned, you would have seen egg-on string appearance. You would have seen a egg-on string appearance. And coarctation of aorta does not result in cyanosis. Coarctation of aorta does not result in cyanosis. So answer here is going to be because of this figure of 8 appearance. Because of this figure of 8 appearance, because of this figure of 8, the answer is going to be TAPVC, that is total anomalous pulmonary venous connection. So cyanotic heart disease with figure of 8, it becomes TAPVC. It becomes TAPVC. Moving on to the next question. A 8-year-old child presents with enuresis. So this is what? This is nocturnal enuresis. This is nocturnal enuresis. Okay. Now, the parents mention that child had a fall for bed from once, but no other significant medical history. There is no sign of UTI or neurological deficit. What is the best next step in management? All right. So they are basically asking you what is the management? What is the management of nocturnal enuresis? That is what they're asking. What is the management of nocturnal enuresis? That is what they're asking. So as far as nocturnal enuresis management is concerned, you have to understand there are 3 steps in management. A, if A doesn't work, then B, and if B doesn't work, then C. All right. A is what? A is always motivational therapy and behavioral modification. A is always behavioral modification plus motivational therapy. What is behavioral modification and motivational therapy? Basically, we will when the baby is, what are the behavioral modification you can do? Think logically, right? In the night, when the baby is going to, in the night, when the baby is going to go to the washroom, going to sleep, before that, ensure that the baby passes urine. That's it. Right? So that he doesn't wet himself. Ensure that he doesn't take any caffeine or caffeinated substance in the night, so that he doesn't have urge to micturate at the night. So these are simple behavioral modifications and they work in a lot of individuals. Along with that, you will do motivational therapy, so that when the child doesn't pass the urine on the bed in one night, you'll give him a star or chocolate or motivate him. This is the first line of management. This is the first line of management. The second line of management, what is called as the alarm therapy or the conditioning therapy. Alarm or conditioning therapy. In this, what we do, we give him a underwear, or we give him a undergarment which has an alarm attached to it, and that undergarment senses moisture. So as soon as the baby passes urine at night, what's going to happen? Immediately the baby is going, the alarm is going to go off and the baby is going to wake up. This will condition the baby that as soon as you have to pass the urine at night, you will need to wake up. This is second line of management. The last line of management, the third line or the last line of management is pharmacotherapy. It is pharmacotherapy. Why is pharmacotherapy the last line of management? See, till the time you give the drug, child will not bedwet. But as soon as you stop the drug, child will start to bedwet again. That's why pharmacotherapy is always considered the third or the last line of management. If you look at the options, start anticholinergic drugs. This is drugs or pharmacotherapy. Oxybutynin, again drugs. Desmopressin, again drugs. So even with that, we can rule out all the B, C and D options. Okay. Behavioral modification is the first line of management. That is the next best step. The answer is going to be that only. The answer is going to be start behavioral modification. Answer is going to be start behavioral modification. All right. So Dr. Varun is saying that here they had given a boot-shaped heart. See, if they had given you cyanotics, if they had given you cyanosis along with boot-shaped heart, if they had given you a boot-shaped heart, then it's going to be tough. You're absolutely right. The image that has been provided to me in the recall, and obviously recalls are based on your memory. So some person might have seen a figure of 8 appearance, some person might have seen a boot-shaped heart. If you're confident if you saw a boot-shaped heart, then yes, you're right. Answer is going to be tetralogy of Fallot. If they gave you a figure of 8 appearance, like this, then the answer is going to be TAPVC. If they gave you egg on string, appearance, then answer is going to be TGA. Answer is going to be TJ. So it all depends what X-ray was given to you. It all depends what X-ray was given to you. All right. So if they give you if, for example, let me just add here only. 1 second. Let's say this X-ray was given. Let's say this X-ray, this was the X-ray. Let's say this was the X-ray which was given. Let's say this was the X-ray which was given. If this was the X-ray which was given, this you can see is a boot-shaped heart. You can see this is a boot-shaped heart. All right, you can easily make out that this is a boot-shaped heart. If they had given you this, then yes, you're right. The answer is going to be tetralogy of Fallot. If this was not given, if this X-ray was given, this figure of 8 was given, then the answer is going to be TAPVC, total enormous pulmonary venous connection. So you're absolutely right. Yes, sir. If there was boot-shaped heart was there, the answer is going to be tetralogy of Fallot. Don't need to worry. The answer will be dependent upon which X-ray was given to you. Obviously, these are recall questions. Somebody else might have thought of figure of 8 in that. They might have been wrong. But if you're confident it was a boot-shaped heart, it was this X-ray which was given, which was boot in shape, then you're absolutely right. It's going to be tetralogy of Fallot. All right. So that depends upon what kind of image was given. All right. Now let's come here. Let's come to the next question. A 9-month-old infant is brought for routine checkup. Which of the following developmental milestone is likely to be present? It is likely to be present. So you have a 9-month-old infant. Which of the following milestone is likely to be present? Let's look at the options. Mature grasp. See, mature grasp comes at 1 year. Immature grasp. Mature pincer grasp. Mature pincer grasp. See, immature pincer grasp. Was it pincer grasp or was it just mature grasp? Was it pincer grasp or was it just mature grasp? Okay. If they had asked about mature pincer grasp, the answer is going to be 1 year. The answer is going to be 1 year. Immature pincer grasp. Immature pincer grasp. Immature pincer grasp comes at 9 months. Immature pincer grasp comes at 9 months. Okay. Then can hop on 1 foot. Hop. See, hops. Hops has 4 letters. Hops comes at 4 years. Running comes at 18 months. Running comes at 18 months. Creeping comes at 9 to 10 months. Creeping comes at 9 to 10 months. So they're giving you a mature pincer grasp and the other option was creeping. The better answer is going to be creeping. The better answer is going to be creeping because it comes at around 9 to 10 months. Creeping comes at around 9 to 10 months. Okay. The better answer is going to be option B, creeps. The better answer is going to be option B, that is creeps. If they had given you mature bidextrous grasp, then mature bidextrous grasp is the better answer. But most likely they had given mature pincer grasp. Mature pincer grasp actually comes at 1 year. Creeps comes at 9 to 10 months. The best answer is going to be option B, creeps. Okay. Answer is going to be option B, creeps. Next question. A teenage boy previously raised as a girl presents with primary amenorrhea. A boy and lack of secondary sexual characteristics. Lack of secondary sexual characteristics. Alright. On examination, has tall stature, small testes, gynecomastia. You know this is going where? This is going towards Klinefelter. This is what? This is nothing but Klinefelter syndrome. 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 If there is Klinefelter syndrome, what is the genotype? Answer is going to be C. It is 47XXY. That is what happens as far as Klinefelter syndrome is concerned. Next, we come to the next question. A young boy is brought to the clinic for developmental assessment. He has prominent epicanthal fold, a single transverse palmar crease, hypotonia and intellectual disability. Facial features appear flat with upslanting palpebral fissure. What is the most likely diagnosis? So this is very easy. Just 1 second. I'll show you an image also. Let me show you an image also here. Just give me a moment. Just show you image once. Just give me a moment. All right, so this is the image. Can you see this? Can you see this? This in this image, just took some time. There is upward slant. In this image, you can make out, just give me a moment. You can make out the upward slant of the palpebral fissure. You can make out the upward slant of the palpebral fissure. You can appreciate the flat facial profile. You can appreciate the flat facial profile. You can see the epicanthal fold. Epicanthal fold is fold over here. And normally you have two transverse creases. They will have a single transverse crease. They have a single transverse crease. All these symptom things point towards what this, you can see this. This looks like a Down syndrome child. This is a Down syndrome child. The answer is going to be Down syndrome. The answer is going to be Down syndrome. So prominent epicanthal fold here, single transverse crease, a flat facial profile, all these things point towards Down syndrome. All these things point toward Down syndrome. Moving on to the next question. A newborn is born to a diabetic mother, presents 24 hours of life with a blood glucose of less than 35. So this is hypoglycemia. This is hypoglycemia. Hypoglycemia, child is symptomatic. So remember, we had discussed as far as hypoglycemia is concerned, hypoglycemia can be symptomatic or it can be asymptomatic. It can be symptomatic or it can be asymptomatic. If it is asymptomatic, you can give oral feeds. You can give oral feeds. You can give oral feeds. But if it is symptomatic, you have to give a bolus. You have to give a IV bolus. You have to give a IV bolus. Of what? Of glucose, obviously. You have to give IV bolus of glucose. So the answer is going to be administer IV glucose and recheck blood glucose after 20 minutes. The answer is going to be option C. The answer is going to be option C. You have to give IV glucose and recheck blood sugar after 20 minutes. Not just recheck blood sugar after 20 minutes because you have to give IV fluid, not oral feeds. Oral feeds is if the child was asymptomatic. If the child is symptomatic, you have to give IV glucose. You have to give IV glucose. You have to give IV glucose. Next question. Which of the following genetic syndrome is caused by deletion of short arm of chromosome 5? So this is easy. This is Cry-Do chart. Cry-Do chart is caused because of 5p deletion. Cry-Do chart is caused because of. And what is the characteristic feature? What is the characteristic feature? A cat-like cry. A cat-like cry. So they have a high shrill or a cat-like cry. That is Cry-Do chart syndrome. That is Cry-Do chart syndrome. Next question. A 12-year-old boy presents with short stature. On evaluation, the bone age is less than chronological age. The bone age is less than chronological age. There are no dysmorphic features. Child is otherwise healthy. Alright. So if there are no dysmorphic features, you can rule out achondroplasia and chondroplasia because they will have dysmorphic features. Right. The only thing that is left is constitutional delay of growth and puberty and familial short stature. See, in familial short stature, the bone age is equal to chronological age. Only in CDGP, the bone age is less than chronological age. The bone age is less than chronological age. And CDGP also is the most common cause of short stature and a delay in puberty. So the answer is going to be option A. A constitution delay in growth and puberty. A constitution delay in growth and puberty. Constitution delay in growth and puberty. Alright. So best answer is going to be constitution delay in growth and puberty. Since there are no dysmorphic features, achondroplasia, chondrodysplasia, these are ruled out because they will have dysmorphic features. They are genetic syndromes. They will have dysmorphic features, so they are ruled out. That's why option C and option D are not the answer. In familial short stature, bone age is equal to chronological age. That's why familial short stature is not the answer. The best answer is option A. That is constitution delay in growth and puberty. With this, we come to the end of the recall session. If you have any doubts, please follow DBMCI channel. You can ask their doubts there. You can also mail me at this mail address. This is my personal mail address. Feel free to mail me. Whenever I find time, I will definitely reply to any of your doubts that you are going to have. Alright. That's it from my side today. Thank you and have a nice day. The paper was easy. If you are someone who unfortunately doesn't pass this time, don't lose hope. Next time, always, you will definitely pass. Alright. Ensure that you go through your own notes, revise, practice more questions. Ensure you do pass 5 to 7 year FMGE PYQs thoroughly, and next time you will definitely pass. But I hope everyone passes this time itself. Thank you and have a nice day. सर आपका एक